Hello everyone, this is Kitty Clinical here with another video, and today we're going to be talking about acute pancreatitis, specifically in the setting of Step 3 CCS, but also pretty much for anyone who wants to do admissions overnight, things to look out for if you're a resident. So let's go ahead and jump to it. So things that you want to keep out for patients with severe abdominal pain. Usually it could be like in the epigastric or left upper quadrant. Sometimes it'll radiate to the back because, again, part of the pancreas is retroperitoneal, right? And then you've got symptoms such as diarrhea, nausea, vomiting. You want to look out for risk factors. So in the history, you want to see, does this patient have a history of gallstones? Are they an alcoholic? You want to also take a look at their vitals. What is their temperature? What is their heart rate? On exam, you'll do your exam, obviously, but on Step 3 CCS, they'll tell you exactly what to examine or exactly what the findings are. You have to be the one to determine what organ systems to examine. So obviously, if the patient's coming with abdominal pain, you want to do an abdominal exam at the very least, right? I would also do heart, lungs, constitutional. And, you want it to be a focused exam if this is an acute pancreatitis. And let's say this patient's in acute pain. You want to be able to triage and manage the most important things first. The less important things can wait, right? So by the time this patient comes to you, if you're a resident and you're doing the admission, hopefully by that time, the emergency doctor would have already ordered an abdominal CT, and that would have shown the findings of the acute pancreatitis. Hopefully, they should have already done an amylase lipase. Usually, lipase is the one that is more specific or better, you could say. So some people might not even go with the amylase. They might just order the lipase and then just call it a day. You also want to look at, other things like the CMP. That'll give you your liver function test. You want to look at the CBC, see if they have a white count, see what their hemoglobin is. Are they bleeding? Because that could also lead you to another rabbit hole, right? And then there's other things that you could do. I mean, the abdominal CT is the test of choice, but you might have come across an X-ray, you might have come across an ultrasound at some point during the journey of diagnosing this patient. The things you want to look out for acute pancreatitis, especially when you're doing admission orders, is you want to definitely provide aggressive supportive care. So oxygen, make them NPO, which means nothing by mouth. You want to give them IV fluids. Now that is a big thing that you need to do. You need to make sure this patient stays hydrated, because if they've got acute pancreatitis, they're going to be at risk for dehydration, right? You also want to make sure you do ins and outs. You want to monitor their urine output. You want to hopefully control their nausea. And you want to give them pain relief. That's the other big thing, right? Now, most people will tell you, maybe a few years ago, they might have said, don't give morphine because it contracts the sphincter of Oddi. But what they've found recently in some of the other studies have been that basically all of them do that. So Dilaudid will also possibly contract the sphincter of Oddi. So what they say now is, well, they used to say that you would avoid giving morphine, but realistically, it doesn't really matter at the end of the day. And that's probably still something that's true if you order something on CCS cases. I wouldn't fault you for ordering Dilaudid if you know about the old facts and you decide, let's just be safe about it and not order morphine. I think that's totally fine. Giving a little bit of Dilaudid or hydromorphone is going to be completely acceptable. The other controversy is antibiotic use. Now, a lot of people might say, oh, you don't really need antibiotics. There's no acute infection. But if there is acute necrosis, then you might want to consider it, right? And that would all depend on the clinical picture, the radiological findings, and things like that. So they don't really recommend it. If you do order it, it would be for prophylaxis. But keep in mind, folks, that there's such a broad differential of things that can cause pancreatitis, right? There's gallstones, alcohol, right? There's also hypertriglyceridemia, which we're seeing a lot of. patients with high cholesterol panel, like their triglycerides being high, is definitely going to put them at risk for acute pancreatitis. And that's all definitely why, if when you're ordering the labs, it wouldn't hurt to order a lipid panel as well. But effectively, what you want for this patient is you might want to consider an ERCP. That's probably leave that up to GI, right? But when you're doing your orders, definitely consult GI, and then you want to also consult general surgery because they might need to get a cholecystectomy. So let's go over some of the orders again for this case, acute pancreatitis. You want to look at, when you're doing the diagnosis, amylase, lipase, BMP. I would just do a CMP because that gives you the liver function as well. But if you're going to order BMP, make sure you order the liver function, the LFT. In addition to that, make sure you get the CBC. As I said before, there should have already been a CT abdomen pelvis. So that should be fine. Other things you might want to consider, you want to look at other differentials, right? So if by the time you're seeing this patient, they might have already done a troponin to rule out cardiac, because as you know, nausea and vomiting, you don't just assume that's a GI thing. It could also be cardiac, right? You might have learned in medical school that an atypical presentation of a heart attack is GI symptoms. So troponin, EKG, you might want to get coags, ABG if they're really concerned about shortness of breath. Triglycerides, I would just do the lipid panel, UA to rule out an urine infection. Blood cultures, you don't necessarily need them, especially if you already know the diagnosis is acute pancreatitis. It wouldn't hurt to order a blood culture if you're concerned about sepsis, so that's completely acceptable. If they're a female, you might want to consider ordering an HCG just to see if they're pregnant. And if you're going to go with a BMP, don't forget to order other things like a MAG and FOS. You're not wrong if you don't order it or if you forget to order it. But typically, patients with acute pancreatitis, maybe they're not really eating the best. So you want to watch out for the magnesium levels and the phosphorus levels. So therapeutic-wise, you want to give them normal saline. You could also go with lactated ringers, I'm sure, but the normal saline is probably what is most acceptable. I usually stick with normal saline in general. Some people like to go with lactated ringers, but I think for most people, for most CCS books out there, the recommendation, at least for pancreatitis, is normal saline. Now, realistically, there's not really a whole. You could go on and on about lactated ringers carry a small risk of lactic acidosis. It has all these other things in them that can do stuff. Just stick with normal saline, 0.9%. If you're really not sure, if you just want to keep it simple, oxygen, NPO status. And then, as I mentioned before, Dilaudid or morphine, either one is fine, but most people like to go with Dilaudid just to be on the safe side. Don't forget to consult GI. Don't forget to consult general surgery. Well, you don't necessarily need to consult GI. You could, but again, you leave it up to you to see whether or not you want to do that. The thing about consults is that you want to look at this from the perspective of the consultant, right? If they're getting a consult for something that they think is not necessary, or they think, you don't really need to consult me because you can manage this on your own, then you're just going to piss off a lot of specialists. You're not going to be very well liked in the hospital. That being said, when you're doing consults, you want to make sure you CYA, you cover your ass, because if you mess up something and this goes to court, they're going to be like, oh, why didn't you consult this specialist? It's a kind of a double-edged sword in that sense, right? Because there's something called defensive medicine where you have to consult the specialist in order to make sure you have the most informed decision. So if you don't know the answer to something, it's not wrong to consult GI if you're not sure, but general surgery is the one to consult for the most part, because you want to make a determination whether or not they need to go through to get the cholecystectomy if you're concerned about gallstones, right? Don't forget about the antiemetics. So you can do promethazine, Phenergan. You can also do Zofran. there's nothing wrong with Zofran. And then obviously you'll make sure when you're doing the orders on CCS cases, this is obvious, but when you're doing it on the computer for your step 3, don't forget to also order a blood pressure monitor, pulse oximetry, cardiac monitor. Don't forget to order vital signs. And if you want to measure the urine output, that's fine too. Don't forget to order a Foley in that situation. And then where should you be? This is also kind of a hot topic. If it's acute pancreatitis, a lot of people can probably manage that on the floors. But there are a lot of people who would recommend that you move them to the ICU, depending on how severe their symptoms are, right? Because if it's an urgent thing, like they need to go through surgery stat, and it really depends on how bad the pancreatitis is what I'm saying. So you don't necessarily always have to send them to the ICU, especially if they're not really if they're hemodynamically stable and this is just like a mild pancreatitis that is just like an observation status, then that should be fine. But you know, obviously when you go to the sequencing, make sure you give pain relief and IV fluids first, because ideally you should be giving that as soon as possible once you establish the diagnosis of acute pancreatitis. So that's it, folks. I hope you learned something from this case. Pancreatitis is a broad topic. You know, you could go on and on with a lot of videos, but I hope that I was able to hone in on the most high yield things that you shouldn't be missing when you do an admission order for acute pancreatitis. Take it easy, everyone.